So if you have to just understand that why we have moved from laparoscopy, because this is the greatest discussion today and the greatest source of reason why people, they don't accept or they don't incorporate that in their surgical practice, is that why do robotic when we can do laparoscopy? Let me just take you with communication. All of us do remember this phone, right? But do we have that in our pocket? We all have smartphones. And the simple reason is that the amount of the same communication, that means making a call, receiving an SMS, or receiving a message, is mind-boggling what you can do with a smartphone rather than what you could do with an old phone. But you're still using a mobile phone. You haven't gone in using the dial phones or the standalone phones, which, if you ask me the analogy, that is the old open surgery, right? This Nokia that you can see is the laparoscopy, and the smartphone is what the robotic surgery today is. So these are some of the, Dr. Fred Moll is probably one of the pioneers in setting up robotic surgery, and Dr. Mani Menon is one of the pioneers in Henry Ford, which actually did the clinical trials with the Da Vinci robot and brought it into clinical use. So 20 years of building. Now, when you talk about robotic platform, the most and the well-used platform is Da Vinci, and that's by the Intuitive Surgical. They have a long history of making this technology perfect to the point where we can use. So we are actually using the 4th or the 5th generation of what they started off. They started off this kind of robotic platform. And today, what we are using is Da Vinci Xi. Okay. So this is how it has progressed over the years. So you can, in fact, a lot of new things have got added and making it more and more surgeon friendly, a more dependable tool, and so that we can use. So if you look at it, new technology always comes in. And the reason for new technology is that the older technology was not giving what I really wanted. So if you talk about robotic surgery, there are no robots like Chitti or Ravan. But what we have is a robotic system which has basically 3 components. What are the 3 components? The first and foremost is a surgeon console. This is a console through which there are wires that are attached to the ports or the instruments that we use through a motherboard or through a computer. Okay, the surgeon gets seated at the console. They see the surgical field through this stereoscopic viewer, and then use hand and foot control to be able to do the surgery. So this is how the surgeon console looks. This is these are the foot pedals that we have. This is the armrest, where this is the place where we have a lot of things where we can control or change or make the electrosurgery. These are the stereoscopic visors through which we see a 3D stereoscopic vision. And then we have all these features that will then we use the masters. These are the masters which we put in our fingers and rotate, move up and down. And by these movements, we actually manipulate the instruments inside the patient's body and perform the surgery. So you can see this is how a console works. You can see I'm manipulating these masters. And when I manipulate these masters, there is a surgery that's happening inside the patient's body. This is the foot switch panel. They have the electrosurgical units. These are the camera, clutch, and so on and so forth. We can show you if you ever get a chance to come inside our operating room, and most of you do welcome. So these are the foot switch that we are using. You can see I'm using my foot to use the foot switch, and we are using the masters with our hand. So once we have this, these are the visors through which we see the inside of the patient's abdomen while we are operating. Again, I can show you. So these are the movements. You can see how we move the masters to be able to perform the surgery. So you can move the masters in any way. It moves like a wrist inside the patient. And this is how we are cutting, coagulating, pushing, dissecting, and so on and so forth. All the actions of a surgery that you could do with your bare hands, you can do with the use of these masters. And this is a slave technique in which what I do in the masters, my slave or the instrument end performs exactly what I'm trying to ask it to do. So it's a completely in control. There is no autonomous movement happening. In fact, there are multiple safety features that are there here, which actually can prevent a mishap or a problem. So this is how I move my masters and then coordinate it by movement of the foot switches, which are here. So there is a camera, clutch, and a swap. And this side, there are left and right electrosurgical units. Then you look at the camera. Now, these cameras have 2 telescopes, one for the right eye, one for the left eye. And that is how you get a 3D stereoscopic vision that you have to see. The second component of this, these are the three components. I spoke about the surgical console. This is the patient cart, and this is so-called the vision cart. The vision cart has a screen. So the surgeon sees through this, but the rest of the OT people can see what's happening on this vision cart. These are the arms which will get attached to the ports. I'll just show you in a brief video to show how the draping of the patient cart. So that's the patient cart. These are sterile drapes that we drape on the patient cart. These are the robotic arms which are written 1, 2, 3, 4, and then they will get attached to the ports on the patient's abdomen. So you can see these are the arms that are getting draped right now with sterile drapes so that the surgical field remains sterile. Okay. This is where the instruments will get fit later. So that's the draping. The draping has finished. And then we move this robot. You can see that's happening there in the operating room. You can see there is a patient here over which this patient cart or robot moves into. That is the patient. These are the ports that have already been placed. These are the laser points that guide how to place the robot for correct surgery. And once this is over, see there are crisscross two lines which comes on the main port where the camera will get fixed. And these robotic arms are then fixed onto these ports. Okay, they look like laparoscopic ports to begin with, but this is how the arms will get fixed. Point the scope at the target anatomy, then press and hold the targeting button. So you can see that is the targeting of the surgical anatomy taking place. Once the targeting occurs, the boom moves on its own, and then it will settle on a point which will be the right for you to operate. There's a lot of computer-assisted work that's going on. And then we dock the other arms onto the ports. Okay, and there you begin the surgery. So once that is done, these are the size of the instrument that you are actually using to manipulate. This is again a same thing that I'm trying to show of once that docking is done, then I will start operating, and that is where you will operate from it. These are the masters that you use. This is the OT setup. That's the patient there. This is the robot that has come from the side. These are the people sitting in between the legs in gynecological surgery. That is the surgeon console. These are the other screens that the rest of the people in the OT can watch what is happening. So if you are a budding surgeon, the questions you should ask even before you talk about that, is robotic surgery expensive? Should I start a robotic program? Should I learn to be a robotic surgeon? What should I do? So the question is that can all surgeries and can all surgeons perform all surgery laparoscopically? Probably the answer is no. So you can push the envelope. That means do those surgeries which you have otherwise would have gone and done an open surgery in a difficult scenario. Use the help of robot to be able to do that in minimal access surgery. Okay, so you can push the envelope. You can push the envelope in these complex situations. They're called complexity multipliers. So there are large specimens, that is, there are uteruses which are very big. Patients are very obese. There are a lot of adhesions inside. There is endometriosis, which is a very difficult disease to operate. And of course, there could be combination of pathologies. I actually began the journey of robotic surgery in 2012 in the month of August, which was autumn. And at that point, I had trained myself as a laparoscopic surgeon, and I felt I could do everything laparoscopically. And I was introduced to this big machine. You can see there are 3 parts. It occupies the most of the OT. And I had a mentorship, but I was thinking where I can use it. And then I realized by auditing my own cases that there are 2 situations where I can use it. And I made good use of it in the last 12 years. And now, with the experience that we have now here at Apollo, more than close to 700 cases I've personally performed. And I can do most of my complex benign surgeries by the help of robot without converting them into an open surgery. So what is the evidence? There is evidence that if you do robotic hysterectomy with the help of robot, it's faster modality. And believe me, it does happen the same way in ROT as well. And if you look at the larger picture, if you can bring the patient in, send the patient home in 24 hours, minimal medication, minimal rest, patient can go back to surgery in 5 to 10 days. There is definitely a larger picture there. You may think that today the cost is more because the patient may have to bear a little bit more cost, but look at the same way. You pay more cost for a smartphone, but how much more can you do with that? Okay, so that is what is some of the paper that we have also published, where we compared our robotic to laparoscopic hysterectomy and found that our conversion rates from 10% came down to 4.3%. This is a very large. So when we talk about fast track hysterectomy, this is really an old data, but you can see the robotic surgery, although have not crossed our laparoscopic surgery, but we are definitely doing a lot more these days. Show you 2 small or 3 small videos of how we do robotic surgery. So this is a myomectomy surgery that's going on. That is a hot shear or a scissor that we talk about. That is the fenestrated bipolar forceps, which is used. And then that is the dissection that is going on to remove the myoma from the intramural space of the uterus. And thus you remove the myoma and then go ahead and suture the defect in the uterus or the hysterotomy incision that you made. So this is a simple method of showing of how we can perform a simple surgery called myomectomy. It may sound simple, look simple, but if you try to do this same thing laparoscopically, because of the minimal maneuverability of the instruments, it is sometimes very difficult and very challenging, especially when you want to suture. Here the suturing looks almost as if you are suturing with your hands in open surgery. But in laparoscopy, as I told you in the beginning, it was a counterintuitive movement. So if you want to move the instrument this way, you have to move your shoulder all the way to the other side and do it. So it's like a counterintuitive movement, and it is technically very, very challenging. The learning curve is also very, very long. So this is a small video to demonstrate how one can do a myomectomy and then reconstruct the uterus back to its original shape, so that the patients after 3 to 6 months can plan her reproductive career, because that's the reason mostly patients undergo this surgery. The second surgery that we do is hysterectomy. This is a published technique of we call a Sinha-Apollo technique, in which we decide or propagate a stepwise fashion of doing this hysterectomy. So the step 1 was preparing the robot. Step 2 was putting the instruments, then putting the getting the robot in place, targeting the surgical anatomy, which we just showed you, docking of the arms, and then introduction of the instruments. So for hysterectomy instruction of the instruments, we take 2 instruments. This is my dashboard where I can select my energies. This is how I'm using the energy, the bipolar and the scissors to cut and coagulate the ligaments of the uterus to ultimately perform the hysterectomy. I'll just let you watch the video for a minute so that you can understand how we can perform this surgery. That is the left uterine artery that we are coagulating and cutting right now. And that's the colpotomy that is going on, where we finally sever the uterus away from the vaginal edge. Once the uterus is retrieved, then we go ahead and suture the vault. So that's a simple way of doing a hysterectomy. The other thing that we use this surgery, this technique or this tool to use is do a endometriosis surgery. So that's the pelvic side wall dissection going on. And you can see that's the ureter, which we are dissecting away. That is the medial leaf of the broad ligament. That's the right ureter, which is getting deflected laterally for us to reach this uterosacral nodule to take the uterosacral nodule away. Okay, so that's an endometriosis surgery that's going on there. That's the medial leaf of the peritoneum, which is being also removed because there are multiple endometriotic nodules on that. This is called peritonectomy. Okay, so what are the barriers? Now, there are multiple platforms available in India right now. What I showed you is the Da Vinci that we commonly use, but you have Hugo by Medtronic, you have Versius by CMR, you also have Mantra by SSI Innovations. So many surgeons, although they have access, there is some barrier to their utilizing in there. One is a psychological. Now, we are creatures to our habit, we are resistant to change. But we must also remember that change is the way forward. We are also fear of unknown. We are good at doing something. Then we think, why do we want to change? Why do we want to do something new? But we must understand that unless you try something new, you will not understand what value it is adding to your practice. You can only connect the dots in the as backwards, not in the future. So you have to try and based on your gut feeling or your understanding or what you have learned till now to be able to take on challenges for the future. A very simple editorial which I will come to you is this gentleman called Dr. Roy Pitkin wrote this 5 points when the laparoscopy was initially getting established. That is there technical feasibility? How well can we assure quality? What is the appropriate credentialing that's going to happen? Is it an experimental therapy? And who's going to bear the cost? But 18 years later, in another editorial, the same gentleman again wrote that laparoscopic surgery established scientific base and developed as educational method and become integral part of practice of gynecology. The same thing will happen with something like robotic as well, because it's just a advanced form of laparoscopic surgery. But that's not just the future. Future is many more things. You have the use of intraoperative dyes like infrared dyes, which we can use with infrared cameras, or you have VR assistance now, AI assistance now. So the possibilities are limitless of what we can do. If you look at the platforms that are available, some of them are available in our country. All these three, including Da Vinci, are available, but the other three are also available in the world, which we don't have at the moment. So it's not money for nothing to use robotic surgery. But I would say it's a glass half full right now. It's not half empty where you can use this. So all those students who are here today, whether you are in training or about to think of taking a surgical program, computer assisted is an enabling technology and the next logical step. There is economical feasibility is the crux of us using any new tool. And effort should be translated to give benefits of minimal access surgery to larger patient population. And of course, by doing that, reduce the open surgery for benign gynecological disease.